Excellent. So should I start now then?
Yes, please.
Good. I'll be mindful of everybody's time, so I'm going to just share my presentation here real quick. Let me share my
I did to a stop.
no
Okay.
problem. Yeah, I got it here, and let me see. Do you see it now? Oh, yeah. Screen and share. Let me know if you see my presentation. I'm going to. Okay, let me see. Present. Okay, do you see it now?
Yes.
Excellent. Let's start here real quick, and I'll just be mindful of everybody's time. So first of all, let's talk about what happens in practice with all these. I mean, it's good to know the theory, it's good to understand it, but more important than that, it's good to choose when to use it and what patient to use it so that you can achieve a good outcome. And therefore, so patients learn to believe more in this field that continues to grow. I mean, over time, we're constantly learning over time, all of us, and that way, it leads to improvement overall. So I'll give you some decision-making rules. None of these rules that I'm going to be presenting, it's something that you have to either know by heart or they're not carved in stone. I want you all to use this as guidelines, right? It's something that can help you make a decision. And if at some point you have a doubt with a decision in a patient you have, I mean, make sure to contact us and we'll try to help guide what you're doing, and we'll all learn in the process. Now, briefly, as we know, the main differences between the three that I'm going to be talking about: PRP, which is a blood draw for place and concentration; the adipose-derived stem cell obtained through harvesting; and the bone marrow through a bone marrow aspiration. Right? That's just briefly. Now, what is in the process of platelet-rich plasma, and there's 1,000 different preparations of platelet-rich plasma, which you all need to understand in order to be able to better treat a patient, right? It's not as simple as leukocyte-rich and leukocyte-poor. There's a lot of other components that if you understand them better, you can sometimes inject a patient with minimal discomfort and obtain the same or even better result. So it's a simple blood draw and centrifugation that will promote healing and will reduce inflammation. Now, what are the benefits of that? Sure, improve healing, improve recovery time, and studies have shown that there's strong evidence of the benefit of its use for tendinopathy. See, I put it there in blue so that if you're just passing this in 2 minutes that you have to review it, you can remember. Tendinopathies and mild osteoarthritis. Even in some cases of moderate osteoarthritis, you will see improvement, but for the cases of mild osteoarthritis, you will see great improvement. Another benefit is it's not costly to the patient, and this is just easy to obtain and easy to process in your office. What you have to keep in mind, as I mentioned before, there's many different preparations. There's companies that want to sell you just a yellow tube to prepare it in your office and will not give you the yield you have. And in the end, it will hurt your own reputation, right? Because patients are not getting better. Now, while it helps with discomfort and it helps with a lot of soft tissue, it does have limited regenerative potentials at the time of talking about cartilage or meniscus, for example. Now, if we compare that to the adipose-derived cells, right, which the mechanism, yes, it involves a lot of differentiation and paracrine effect of cells, but the advantages are not only a typical patient may have an abundant of adipose tissue, right? But also it's very it's has strong anti-inflammatory effects. Now, one thing that I have noticed over the years is that, I mean, there's a reason why we're actually trying to break that fat a little bit. It's because that fat is thick and it won't go through a syringe easily. So even when you break it a little bit mechanically, that fat has still it produces a mass effect, meaning it's great for joints that are starting to collapse or are reducing space. I mean, I use the word collapse, right? Or even a tissue like a hip where you have to offer some distraction and strengthening up the muscle. It's good to also get it in there because it helps separate the tissue a little bit more than something that's a little more fluid. So that's something to always to keep in effect. I use it a lot in cases of people who have tendon tears with some retraction. Not only do you want to inject it in the tear, but remember that the tear is a space. I like to inject it in both sides of the tear so that its own mass effect can push and approximate the tendon tissue a little bit and therefore produces a better effect. Now, it has shown to have great outcomes in healing and pain reduction. So, and it can be used for mild to moderate osteoarthritis, even in some cases of severe osteoarthritis, but especially of the knee and hip. Now, it has multiple uses. One problem I see, or we have to keep in mind, one consideration with adipose-derived stem cells is that we're not all experts in liposuction like Dr. Randy Miller, right? We're not all plastic surgeons, but at least the good thing is we have to obtain just a little bit of fat if you're treating a simple joint. But what happens when a patient comes who is an elite athlete and barely has any fat, and they say, you know what, can you obtain it from here? You know, trying that could cause a cosmetic defect, so you have to be mindful of that, right? Fat is very forgiving if you take it from the love handles, but in other tissues, it might be a little problematic, and it's a long procedure that it can be time-consuming if you're not used to doing it. Now, you compare that to a bone marrow aspiration, which is minimally to moderately invasive. It has a lot of effectiveness for the regeneration of cartilage and bone tissue. So for cases of non-healing fractures, for example, is great. For cases of vascular necrosis of the bone on the hip, I have a lot of patients like that. And but it doesn't have that mass effect as much as the adipose tissue has. It is quite safe. And the main concern is actually patients' fear that they think you're going to their spine, but in reality, you're going to a very, very safe area of the pelvis, not the hip. And, you know, some patients after 2 or 3 weeks, they still have some pain on the extraction site. That feels like a bone bruise, right? It is skill dependent, but it can be easily learned. Another consideration you need to have is that as we age over time, yes, we accumulate more fat, but we actually have a lower mesenchymal stem cell yield from the bone marrow. Now, going to what we need to know and learn today. Number one, yes, these treatments are great, but we have to remember and be mindful that these treatments are not everything. They're not the God, right? They need to be accompanied by good patient compliance, physical therapy, and all other modalities that are important and can help bring us a better outcome with the patient, such as shockwave, etc. Right? It's also important to follow up the patient and give the patient clear instructions, because I've noticed over the years that some of the patients that fail treatment are simply because they did not understand what was going on or what they needed to do and ended up damaging the work we were trying to do. And follow up. Always offer follow-up to patient, because it's important not only for you to see what's going on, but also that's data gathering time that you can use it that actually helps you understand that what you're doing is right, and it also gives you more credibility. Now, the algorithm, I'm not going to explain it I'll go to the other slides. I prepared a couple of tables for you that you can print and have it in your office if you want. You can learn it, and that kind of guides you to what is best to use in each patient, right? Remember, these are not carved in stone. These are just some guidelines that you can use. Let's say, so first, I want to start with a comparative analysis. And first, you need to have an accurate diagnosis. I mean, in order to treat someone right, you need to have some imaging studies. You need to have a proper evaluation. Don't just trust the patient that comes in telling you, I have tendinopathy, just because maybe they found it on Google or they misunderstood what his physician or clinician told them. So when you evaluate patients, cases of soft tissue like tendinopathy, for example, you can see that do very well with PRP, or cases of mild osteoarthritis. But cases of cartilage defect, for example, it's good to use bone marrow aspirate, and sometimes you can even combine that with PRP to get even a better result than just the bone marrow aspirate. So remember, these three are not competing against each other. They are often complementary too, right? In the cases of one question I've been asked a lot, even on patients that are surgical, well, then I'm not a candidate. Well, they can still be a candidate for PRP or for bone marrow stem cells to help promote better healing post-operatively. But if you're going to do that, make sure you do it at least 4 weeks after surgery, when the swelling has come down. Okay, when there's less complications, and when if something goes wrong from the surgery, the surgeon doesn't want to blame you for having touched the patient, right? That's also important. Now, So step two, what is that? It's important to also keep these factors in mind, right? Not just having the diagnosis, but look at the patient's age. Because you'll see a lot of people say, yeah, but I was told that I'm older, so I don't have as many stem cells. Well, in a patient that's older, I might not want to do a bone marrow aspiration extraction, although I still do. I have patients that are in the late 70s or early 80s, and I still do, depending, because they might not have a lot of fat tissue. So that's something to keep in mind. If the patient has a very large BMI of 40, I mean, I may consider doing an adipose draw. I mean, what I'm taking out is not enough to be a major plastic surgery, but it might create a difference in the patient's joint. Now, if the patient has a bleeding disorder, of course, we're not going to go with PRP. So always keep those things in mind or here on that table. Now, also, step three, what would be? It's what are the prior treatments the patient has had and that outcomes? Like if the patient has failed very conservative treatment, I mean, you could consider trying just PRP. Now, what if the patient has had several sessions of PRP? Are we going to just put him on another PRP and badmouth another clinician saying they don't know what they were doing? Well, the reality is we don't know if what the patient is explaining to us is even accurate enough, right? They might not understand how to explain that well. So we can escalate that to what we think, well, PRP might not be enough to work. Let's go to level 2, and that might help the patient get a better outcome, right? Now, also, there are those patients that are surgical, and we just have to be honest with them and we tell them, you know what, I would not touch you, with a stick. I would send you to surgery, but for some reason they can't do surgery, either because they don't have insurance and they can't afford it, or simply, or they have a heart issue that they cannot have surgery. In that case, as long as they understand that, hey, this might not do the trick and give you what you want, but at least could make you a little bit better, that's important also to dedicate that time. And that's not a time that your PA or your nurse practitioner or your assistant should be giving the patient, talking to the patient. That's a time that you need to dedicate to the patient and respect them, explain that, and it would lead to them being more compliant and more understanding and to have a realistic expectation of what's going to happen. Anyways, aside from that, from the moral discourse, goals, what are the goals of that patient? Well, and what are your goals? If the patient just wants pain relief, I've had patients that say, you know what, my pain is 10 out of 10, doctor. And I said, well, I mean, you're going to go to surgery? No, I don't want to go to surgery. If I can alleviate my pain just a little bit, that will make me happy. If that can buy me some time, that can make me happy. So you can use this table to help you with that. Like if all we want is tendon healing of a tendon that's partially torn, but it's not that uncomfortable to the patient, PRP might do the trick, right? If it's something where we need bone integrity because it's a non-healing fracture or because it's a vascular necrosis, then a bone modulator like BMAC would be helpful in those cases, right? Now, if we're looking at durability, and this is very important, then a BMAC tends to show a little more durability than MFAT or PRP, but that's kind of just a gross guideline. It's ultimately it's going to depend on what exactly you're treating. Now, if the patient simply doesn't have the money for one of these treatments, then we have to also scale it back a little bit and not combine as much. So that's also something realistic that we have to consider. So when we use combinations, well, in cases like, for example, moderate to severe osteoarthritis that also has a lot of inflammation, you can mix PRP and MFAT, or post-surgical or cartilage repair, you can use PRP and BMAC. Easy. I mean, you can review those a little bit later on. So let's go to the fun part. Let's go to the case studies, okay? Now, the case number 1, that lady with the elbow, right? Your staff told you in the office. This is a 72-year-old tennis coach that came with 6 months of right lateral elbow pain that gets worse with gripping, right? She tried conservative treatment, she tried physical therapy, shockwave, multiple things, and then she had a cortisone injected just 2 weeks ago. And she has a tournament in this next coming weekend. And imaging, the MRI shows an ERCB tendinosis, but there's no tearing, right? And the diagnosis is right lateral epicondylosis or tennis elbow, but chronic tennis elbow. What is the treatment? The treatment for that patient is send her home, right? Don't treat that patient. Why? She just had a steroid injected less than a month ago, right? And number 2, that patient is telling you she has she's having a tournament in this coming week. That patient is desperate, and very likely, cases like that, those patients tend to either not follow instructions, they don't take adequate rest because it's a tournament and it's important to her. A case like that, I just sent her home and I said, after the tournament, take like a week or two and then come back. So going to case number 2 is the former high school wrestler. This is a 63-year-old sedentary man with a bilateral knee pain of 8-year duration. It failed conservative therapy, and he has a BMI of 34. Now, he comes in saying, they say I'm bone on bone, which is very common. People come saying they're bone on bone, and they're really not bone on bone. That's just somebody, it's just, many orthopedic surgeons, unfortunately, many of my colleagues, they just don't explain it to a patient very well, or they had an assistant tell the patient, and that's what the patient understood. So in imaging, an X-ray shows some joint space narrowing and some medial meniscal degeneration. He had osteoarthritis stage 2 and 3, different on bilateral knees. What was the treatment for him? In this case, we did an MFAT injection after abdominal harvesting. And when we followed up this patient 6 months later, he had an improvement in pain scores, and he was able to defer his total knee arthroplasty in 1 year after evaluation. So his patient, he was a lot more functional, and that way, eventually he would need a total knee arthroplasty, but the last time we saw him, he had just postponed it, and that's exactly what he was looking for, okay? Now, case number 3. Oh, guess who's back? I said, it's the same lady that case number 1. She just showed up at your office without an appointment, and she's mad because she lost that tournament. And so when you see her, right, it's that tennis coach who has had the pain for 6 months, and she reminds you, and 2 more weeks, because you made her wait, and she wants to get treated. Now, in this case, you still do an ultrasound in office. And why is that? Because even though you have an MRI from last time, I don't know if she got a bigger injury or if something else happened. It's the responsible thing is to look at it again, especially when you have the ultrasound in office. You can do a brief evaluation, and ultrasound showed no change. So the treatment, we did an ultrasound-guided PRP injection and followed up 6 weeks later, and she had resolution of her symptoms. Remember, MRI has shown that she had mild tendinosis, so she responded very well, and then left. Case number 3, and I'm almost done, guys. It's those hips don't lie. And it's a 36-year-old male, a gamer. All he does is professionally, he sits down and plays video games all day. He's had 2 years of worsening bilateral hip pain, and he plays video games 8 to 10 hours a day. And that's a reality of something we're facing. The video game world right now pays so well that people dedicate their lives to that. So he admits to very poor compliance with physical therapy. Keep note of that, right? And this patient has no health insurance. So he's coming to you because he won a lot of video game tournaments, and he's willing to pay, but he still has no insurance because that would be too high of an expense for him to pay. Now, imaging shows subchondral signal change, and he has a vascular necrosis of bilateral hips with a collapse on the left, but no collapse on the right. Now, what was the treatment for him in that case? We did a bone marrow aspiration stem cells. Oh, sorry, I missed that one. Yeah, bone marrow aspiration stem cells combined with an injection of PRP. And following months, 6 months later, his right hip pain was reduced. There was no progression or difference in the MRI. Unfortunately for him, the left hip, which was collapsed, we weren't able to save it. So that ended up in surgery of one side versus both. So, but he had that realistic expectation. Now, what we did in his case, because we thought, you know what, I think we'll be able to save one hip. The other hip, I told him, I don't think I'm going to save it because I'm not going to think I'm going to be able to. So what we did is we just treated one time. I treated the other hip at no charge. I said, you know what, if it helps, great. If not, I don't feel bad that I charge you for that. So the fact that it did not produce any effects there, he was okay with that because he spent not a single cent for that. Now, case number 4, no one will cry on this shoulder. This woman comes in with 1 week old right shoulder pain, worse with her serve. She's a tennis player, and she felt conservative care. Now, she had a history of dislocation of the shoulder 20 years ago, and she went to another doctor who didn't explain things to her and just wanted to do a series of expensive injections. But she was referred by her tennis coach who said, you fixed her elbow, right? Now, on imaging, this patient came in with a partial intrasubstance supraspinatus tear with no retraction and some fraying of the labrum, which was expected from her old dislocation. And diagnosis, she had a partial right rotator cuff tear and some labral frame. The treatment was a combination therapy of BMAC and PRP, and follow-up of 3 months, she had already improved pain and range of motion, and follow-up 6 months later, she had improved function and she was able to play in tournaments. And then she said that her coach sent her regards, who's also her mother-in-law, and who's sending you a lot of patients. Now, what's important about that is that lady that you saw that one time that seemed kind of a little crazy has kept her eye on you and has kept sending you patients because you did something for her. You took the time, you respected her, you understood it, you explained things. Community. And that's it. And then you have my references in case you need to read a little more on that.